it's good time to start. So my name is Maria Hassami and I'm a dermatologist in Scarborough General Hospital. And we are planning to extend our dermatology service to Centenary and Birchmont, hopefully soon. My talk today is about what is new in dermatology, focus on biologics and JAK inhibitors. The reason I thought this talk gonna be helpful because we have a lot of new drugs that sometimes it's, especially for hospitalists and internists from different specialty, if you are not dealing with them, it is hard to even sometimes know what the side effects or complications you may expect or see while they are admitted to the hospital or seen in emergency. And it is getting more and more complicated because, and we are lucky, like as a dermatologist, I feel lucky we are in an era that we have so many trials, so many new medications coming to help our challenging patients. So my focus is mainly on actually I'm going to talk about 4 challenging diseases that I see on an everyday basis. So let's start. Sorry. These are my disclosures. Like I got NRM from different dermatology involved companies, and this talk is supported by AbbVie, and part of the presentation was based on unsolicited basically slides from AbbVie. What is new in dermatology? I'm going to talk about new biologics. I'm going to talk about JAK inhibitors and TYK2, and a bit touch on uremic pruritus and bullous pemphigoid. As I said, these are challenging diseases that in our hospital, I'm dealing with them almost every day. So the list is very busy. I'm gonna go over it quickly. So the biologics that right now we have in dermatology, and it's actually short of a few of them. So these are biologics mainly for psoriasis. So etanercept or Enbrel, we almost never these days we are using it because we have better biologics right now. We have infliximab and its biosimilars. We have adalimumab or Humira and biosimilars. We have certolizumab or Cimzia, which is the safest anti-TNF when it comes to pregnancy. It doesn't pass the placenta, and the only biologic that we know for sure it's not passing placenta. And we have the best safety data for it. We have ustekinumab anti-IL-12/23, which has been around for more than 10 years. We have secukinumab, which is Cosentyx, and we've had good experience with it, which is the first of anti-IL-17 approved in Canada, ixekizumab, which is Taltz, and basically that's the one that also has, like these two have indications for psoriatic arthritis, so we share these drugs with our rheumatologists. We have brodalumab or Silic, which with a black box warning about suicidality and depression. And we have one that is not in this list, bimekizumab or bimekizumab, which is the newest anti-IL-17, and these drugs overall very effective, anti-IL-17. Then we have anti-IL-23, gazelkumab or Tremfya, tildrakizumab or Ilumya, and risankizumab, Skyrizi. These are all anti-IL-23, and they are revolutionary. Like, for example, Skyrizi probably it's our #1 choice. It's very easy, every 3 months injection, and they do magic. So majority of time now, the biologic we use are down in this part, like anti-IL-17 and anti-IL-23. And sometimes we use anti-TNF, or sometimes we use anti-IL-12/23 when there are indications. So This is a chart from the beginning of COVID. We were very worried about the immunosuppression and the effect, especially in the COVID cases. So still our knowledge is close to this, like we know prednisone and cyclosporine, they have the strongest immunosuppression. Methotrexate and mycophenolate mofetil, they come next. Tocilizumab then comes here. We have rituximab on top of all of this, like the highest immunosuppression is rituximab. And then we have IL-20, 12, 23, 17, 23, and apremilast, which is PDE4, that they basically don't have any immunosuppression. We still, like now we have a lot of registries, a lot of data, and we know even with anti-TNF, and like lower than this, we really didn't have major issues. About tofacitinib or JAK inhibitors, now we have more JAK indicated in dermatology, but it's interesting, with pan-JAK, maybe more immunosuppression than when it comes to selected JAK inhibitors. And we have TYK2 that's soon gonna be approved, and or maybe just approved. And for TYK2, we know even they used it to improve, like there was some indications for COVID. So overall, our patients in registries or real life, they really didn't do badly, and their prognosis wasn't worse when they were on this biologics lower than here. Even with methotrexate and prednisone, we really didn't see that much, but all of these biologics are now in the list of patients that they are basically approved for Paxlovid. So that's kind of an advantage. But when patients ask how come that we are approved or how come we can get the vaccination if you don't think that immunosuppression is major, our answer is generally this is a category of the drug, and they actually approve this based on the category of the biologics. But we're really not that concerned about majority of this. Rituximab, high doses of prednisone, high doses of methotrexate and MMF probably. So I'm going to touch base a bit on complications and adverse events of overall biologics and JAK. I have a checklist. Before starting even methotrexate, I ask family doctors to check for TB, Hep B, Hep C, give the shingle vaccine, and make sure all the vaccination, including pneumonia vaccine and influenza vaccine, and now COVID vaccine is up to date. However, for certain biologics, we are not really seriously concerned. For anti-IL-12-23 and anti-IL-17, especially with TB, because mechanistically, it doesn't really affect the granuloma because it doesn't affect the TNF. So it is not a big challenge. Even there were trials in Europe that they didn't require the TB testing for Skyrizi or risankizumab. And in our real life, we are not that concerned about TB with the new biologics, but with anti-TNF, definitely. And with even prednisone and high doses of prednisone and methotrexate, definitely. And Hep C almost, it can be cured, so it's not a big deal. But with Hep B, I always check HBs antigen, HBs antibody, and hepatitis B core antibody. And if there's any case, especially if I send a patient for rituximab and the core antibody is positive, I always want hepatologist or infectious disease to give green lights. Now we have like more records of herpes zoster and herpes simplex in JAK inhibitors. So in these cases, sometimes we do treatment prophylactically for herpes simplex, and for herpes zoster, even recommended after age 18 to get the shingle vaccine. But Shingrix is not a live vaccine, so there's advantage of we can do that without, even while they're on biologic. But the problem is some of this vaccination, if they use after a certain biologic, maybe the efficacy is not the same. Otherwise, they're safe. And about the live vaccine, there's a lot of controversy in real life in children. We don't have a lot of data that they caused huge problem because they are more and more right specific now, but even they are live. But we still don't recommend live vaccine when there are patients on biologics. About malignancies, we want a patient to have the regular annual survey before starting biologics, but it's good to check their skin, especially in patients that they are high risk, because we know biologics and JAK inhibitor, it may increase non-melanoma skin cancer. For solid organs and lymphoma, like there's a lot of controversy, especially with lymphoma, that overall patients with a huge burden of inflammation, they are more at risk. So, and the data from Humira actually showed that it can be protective, but we still warn our patients about these two things. IBD, we know patients with psoriasis, they are more prone to IBD, like uveitis, and other inflammatory conditions. But there are certain biologics, like for anti-IL-17, it may increase the chance of IBD. So we are a bit cautious when it comes, and especially when it comes to those drugs, and especially when there is family history of IBD. With skin, our gastroenterologists have seen, and we've seen that sometimes patients are started on a biologics, for example, anti-TNF, and they may get paradoxical psoriasis. Like instead of treating their psoriasis, they get actually worse. And sometimes we need to change the class of drug. Even in GI, we change it to anti-IL-12/23, but huge doses of generally gastroenterologists do, but that's what we recommend when they get paradoxical psoriasis. Also, there are possibility of shifting from T helper 1 to T helper 2, so we may see extreme dermatitis. In case of JAK inhibitors, we may see acne, and that's one of the side effects that we see in younger patients, and sometimes can be debilitating. And there are a few reports that patients had to stop it, but generally treatable. MS are demyelinating diseases with anti-TNF, but not with the new biologic. Lupus or positive DNA, again with anti-TNF, not the new biologics. Transaminitis, congestive heart failure, weight gain with more anti-TNF, and depression and suicidality. Patients overall with psoriasis, they are more prone to mental burden of the disease, and they may get more depression even with the effect of cytokines. But with certain biologics, we are more concerned, especially with brodalumab. This is a UK biologic checklist from many years ago, more than 10 years, but we still do kind of the same thing. We check patients before starting biologics for TB, HIV, Hep C, and make sure how much phototherapy they received, see whether they are more at increased chance of skin cancer or not. Also, we ask about BCG vaccination. Routinely, we do quantiferon gold, and most of the drug companies, like biologic companies, their patient support program, they do actually quantiferon gold. So my routine is I do both TB skin test and quantiferon gold, especially in high-risk patients. And in Scarborough, we have a lot of high-risk ethnicities. And as I said, I recommend for vaccination to be up to date for pneumococcal vaccine. For example, I ask family doctors to do Prevnar 13, and 2 months later, Pneumovax. And if they have done Pneumovax, then maybe booster of Pneumovax. But I have a checklist for infectious disease based on our infectious disease specialist recommendations. So let's talk about JAK inhibitor. This is new like category of drugs in dermatology, but our colleagues in rheumatology, oncology, GI probably are more familiar with them because they've been around for them longer than us. In dermatology, the indication is for psoriatic arthritis. We still don't have indication for psoriasis, but for atopic dermatitis, we have indication, and soon we're going to have indication for alopecia areata and vitiligo. There are black box warning for majority of this. For TYK2, we don't have black box warning, but the black box warning was about thrombosis, MACE, malignancy, serious infection. And we do we have to do monitoring with these drugs. For new anti-IL-17 and anti-IL-23, they really don't need monitoring. We still may do once a year blood tests because we know those patients are at increased chance of lymphoma, not necessarily because of their drug, but maybe because of the burden of inflammation. But and I routinely ask my patients to do the TB test and chest X-ray yearly when they are on biologic. However, the consensus is for the new biologics, really, we don't need that much of monitoring. And for biologics use for atopic dermatitis, we don't need that much of monitoring, but for JAK, definitely we need. So this is like some diseases that they are treated with JAK, like there's a range from giant cell arthritis, as I said, even to oncology cases like multiple myeloma. I don't know, ruxolitinib is used in oncology that much, but that had been around for a while. And we have like some indications in dermatology now, as I mentioned, like we have tofacitinib for psoriatic arthritis, upadacitinib for UPA or Rinvoq. We have it for atopic dermatitis, and we have recently Symbico, which is another JAK inhibitor that approved for atopic dermatitis. So let's talk a bit about atopic dermatitis. You may think, you know, I think this is not an orphan, but it's a neglected disease because patients quite often they're born with it and they feel it's part of their normal life. They get used to it or they really suffer in silence. But it can be quite serious. Like I had a lot of patients refer to me from emergency with severe atopic dermatitis. They were admitted to the hospital with infection. It's interesting, mechanistically, patients with atopic dermatitis can get superimposed infection because of the lack of antimicrobial peptide and defect in barrier. But in psoriasis, psoriatic plaques, they cannot get infected because of they don't have it's like TLPR1 versus TLPR2 disease, and also, as I said, mechanistically. So they may get eczema or herpetical, impetiginized eczema, they may get severe disease, and each, like 20% of patients with psoriasis, they have itch, but 90% of patients, or even more, they have, like it's one of the main criteria for atopic dermatitis, and it can really affect their sleep, their mental health, and social life. So these are some examples. I actually took them from web, but I've seen like many of these like coming from emergency to my office, like severe eczema herpetical, severe lichenified dermatitis, like all over, impetiginized dermatitis. And I had few cases of Staphylococcus scalded skin syndrome, which is in the childhood, it's probably not a big deal, can be treated unless the patient is really all over. But we can see it in adults, especially in patients with renal failure in our patient population, and that can be deadly. So atopic dermatitis is not just eczema and it's not just skin. It really affects the quality of life. And when it's that severe, needs a good treatment. But the nature of the disease and presentation and pathway and different races may have different presentation. And we are learning more and more about this disease. So it can be consistent, it can be episodic, it can be like there are different phases in different part of the life, like infantile, childhood, and adult, they look different. And even in different ethnicities, we have different presentation. Now we know Asian atopic dermatitis is different than African American and different than European. We actually see more severe cases in Asian and African American. And the response to therapy and even the cytokines are different in different races. So atopic dermatitis is a common disease. 15 to 30% of children, they are affected, but 2 to 10% of adults. So it's not necessarily a disease of children, but in adults, they may have limited disease just around the eyes, hands, or neck, or they may have still lichenified dermatitis all over. And we have increased chance of atopic dermatitis, like 2 to 3% increase in incidence in the past 30 years. So is it environmental factor, patients becoming like more urbanized, or other factors, who knows? But overall, it affects mental health. The patients with atopic dermatitis, they have lower self-esteem, poor body image, anxiety, and depression. And the treatment satisfaction is low because the disease control not necessarily is satisfying. So this is based on patient survey. They all want 96% free of itching. Itch really affects quality of life. I don't know, have you ever been itchy? It's really not easy, you know. You can't concentrate, you can't enjoy anything basically if you get really itchy. They want their skin get better quickly and heal all the skin defects. They want to look normal. Like my patients that they were treated like with biologics, you know, like a few years ago, a young man who dropped U of T computer science because he was actually admitted to our hospital twice and he couldn't cope with his atopic dermatitis. Finally, dupilumab came and he was started on the treatment. So a year later, his feedback to me was, doctor, now I can go and swim. I can have a girlfriend. I can wear a short. I can do bike riding and go to gym, and I can travel alone. You know, you'd never think these are like things that somebody really, really wish at age 21 or 22. And he went back to school and he finished his U of T, you know, got his degree and got a very good job. But I mean, there are for every medication side effects, so we're gonna go over side effects or, you know, comparison of these drugs too. So we have biologics. We have, for example, anti-IL-4RA and anti-IL-13 inhibitor, which is dupilumab. Now we have anti-IL-13 inhibitor too, that it's a drug from Leo. We have, these are specific drugs and targeted. And then we have small molecules for atopic dermatitis. Like these are next level of medication, of course. Like we have our traditional medicine like cyclosporin, methotrexate, azathioprine, and prednisone. But if patients fail those, or sometimes even prednisone alone, we can move on to JAK inhibitors. For biologics, we have to fail also methotrexate and cyclosporin to be able to move to biologics. But for small molecules, JAK inhibitor, we just need to fail prednisone. So for JAK inhibitors and PDE4 inhibitors, we don't have anything right now approved. But these are, I like this slide. This is the mechanism and shows how many cytokines are involved. Nemolizumab, it hasn't still come, but we call it NEMO. It's a drug for IL-31 for the itch. We are hoping that helps our prurigo nodularis and our itchy patient. Tralokinumab, that's the drug from Leo, that's anti-IL-13. Lebrikizumab, we still don't have it in Canada. And we have dupilumab, anti-IL-4/13, that we have it for a while. So these are the drugs and the targeted areas that they affect. These are the treatments we had before, and now we have all these drugs available for atopic dermatitis. And it's evolving, like we have more drugs coming. For example, abrocitinib is the drug that just approved Symbico for atopic dermatitis. We have Rinvoq or upadacitinib for atopic dermatitis, but it had been around previously for rheumatoid arthritis. So our rheumatologists, they have more experience than us with this drug. And these drugs are coming soon, lebrikizumab and nemolizumab. And the tralokinumab, which is like dupilumab, but it's just anti-IL-13, has less conjunctivitis, and that came from Leo. So I don't want to go to the detail of cytokines, but these are all the cytokines, inflammatory cytokines involved in atopic dermatitis, and it shows where the JAK works. And these cytokines, these type 2 cytokines actively activate the sensory neurons and cause itch. So itch signaling is not easy. So there is a new terminology, at least for me, specific inhibition and selective inhibition. So biologics do specific inhibition. They are more like targeted, and selective inhibition, it works in the category and the family of those cytokines. So basically for JAK inhibitors, they have a broader umbrella, and sometimes they actually work in other diseases besides the disease that they are targeting. So it can be good sometimes for us, especially when we have a patient with lichenified dermatitis, lichen planus, or other diseases like lichen simplex. Sometimes, to our experience, JAK work better than biologics. So this activation of JAK signaling, it's a very interesting pathway. We see IL-31 and many cytokines or other mediators bind to the cell receptor surface. The JAK bonds to the intracellular portion of the receptor and activate via phosphorylation. Then basically the STAT is activated via phosphorylation, and p-STAT is released, like phosphorylated STAT is released and dimerized and moved to the nucleus. And then we have p-STAT dimer binds target genes and regulate transcription. And then we have proliferation, differentiation, migration, and apoptosis that we see in these diseases involved. So again, we compare biologics and JAK inhibitor. Biologics are more specific, JAK inhibitors more selective for the drug. Biologics are subcutaneous injection, JAK inhibitors are oral. Once a day, biologics every 2 weeks or every 4 weeks, you know. I have patients even every week because they didn't respond. They have longer half-life, JAK inhibitors shorter half-life. Biologics have shorter onset of action, but really they each like sometimes go fast. But we are talking about few weeks, but for JAK inhibitors in few days, they really, really feel better. The side effects for the biologics, especially we have conjunctivitis in some of our patients, like we are talking about severe conjunctivitis that we have to stop. I mean, oral herpes or eosinophilia, respiratory tract infection, these are not common things, but we are always worried about hermit and parasitic infections in biologics. So if patients are going to an area, traveling, or they have these infections, they have to be treated. But for the JAK inhibitor, we look at LDL cholesterol, upper respiratory tract infection, with tralokinumab, the new drug. We may have headache, acne, and herpes zoster are concerns. For the biologic, we really don't need to do lab monitoring. With JAK inhibitors, we do, and live vaccines are contraindicated in both. So these are the two biologics we have, like the indication and dosage is similar. We think dupilumab is a bit superior to tralo, but tralo has less conjunctivitis, but may have more headache. So these are the warnings. I think these are important for internists to know, like, or like people that see patients in emergency, like conjunctivitis and keratitis may be seen with dupilumab, hypersensitivity and helminth infection, eosinophilic conditions, and patients generally like prior to that were on corticosteroid or other drugs, and withdrawal of that may show after starting this drug, these drugs. The same as JAK, but for JAK inhibitors, we watch lipid and hematologic abnormalities. I mean, gastrointestinal perforation just reported, but it's not really an issue that we are worried about. Hepatic enzyme elevation, we have to be careful about vaccination and live vaccine, but these are basically the black box warning about serious infection, malignancy, thrombosis, and MACE. And as I said, TYK2 doesn't have this black box warning right now. For biologics, we do some screening, you know, like maybe undergo ophthalmologic exam. If they are not resolved because of conjunctivitis, eosinophilia may be seen with DUP, eosinophilic conditions not reported with tralo, but these parasitic infections reported, and if they don't respond, they should not be started. For screening for JAK inhibitors, we have UPA and abrocitinib. We have to do TB testing before. We have to check for viral hepatitis, and we have to evaluate them and after treatment start. And we have to do skin evaluation for patients that they are prone to skin cancers, and check infections. And then there are some blood monitoring, like lymphocyte, neutrophils, platelet. And if they are lower than certain numbers, we're not going to start. And we have to follow and check lipids and also hepatic transaminase. And also we check CK. And as I said, we check for herpes zoster before. Any questions so far? Because I want to change the gear to some other difficult cases or challenging cases we see in our hospital. No questions related to this subject? I guess you are hearing me. So no questions. Okay. So we have, like, one of our challenges, or my challenge in everyday basis, is our patients from dialysis unit, and especially itch can really affect their quality of life. So uremic pruritus is multifactorial, but sometimes it just may start after starting dialysis. So we have to correct, calcium, phosphate, other things like skin moisture, and then we correct everything. We may go to the path of therapeutic agents, gabapentin, Lyrica, like go low dose, naltrexone. We are talking about very low dose, like compounded. Maybe we do UV therapy, which we don't have it in our hospital, but there is a new drug coming, and that's kappa receptor agonist. Like, it's like basically balance. When more opioid activity goes up, itch gets worse. So more receptor has some effects, on basically itch, and then kappa goes up, the itching is controlled. So we need that balance. So this is the kappa receptor agonist, and it doesn't have any effect on mu receptor. So it doesn't give euphoria or respiratory depression, because there were other drugs that they tried before, and it was affecting on both receptors and had some of the side effects. So the new drug is called diphenylkephalin, or Korsuva. It's already approved in US, and it's coming soon to Canada. It's a drug that needs to be given through dialysis. So, and these are some basically studied from published in New England of Journal of Medicine in 2020. So they looked and they see in placebo, they decreased 30%, and in this drug, 52%. I know it doesn't look very impressive, but it was statistically significant. And to be honest, we don't have a lot to offer. So even if we have a little bit of improvement or a percentage of patients improve, I think we're gonna take it, So these are the side effects, some GI side effects, but not huge side effect. And there's no withdrawal or dependence. So there's another study, I don't go to the detail. So any question about, the company really didn't involve dermatologists, so we are kind of in dark. We are waiting for this drug because the company believes that this is just a nephrology related matter, but we know that there are other causes of itch, like bullous pemphigoid, for example, one of them, and I see a lot of bullous pemphigoid in dialysis patients. I've seen patients with scabies, drug reactions like that caused itch. I've seen patients, of course, with psoriasis that they got very itchy as well. Atopic dermatitis of elderly, we call it skin senescence. So there are other causes of itch. So not necessarily everybody that's on dialysis and is itchy is because of uremic pruritus or dialysis itch. So I think in future we need coordination and cooperation with our nephrologists to make sure the patients that they're starting on this drug are on the right drug. But so far we are doing it anyway, because generally they send patients to me, I do biopsy or give the opinion, and then we move on. But we are very excited to see whether the new drug gonna relieve some of the itch. So the last part, I'm talking a bit about another challenge in our hospital and again in every day of my practice. And bullous pemphigoid is a disease of elderly. Sometimes they are admitted, at least, like it's one of most common referrals to me. It can be started with urticarial plaque, and then the blisters start. It's very itchy. And generally patients are over age 70, but patients may be without blisters for a while. They may come with eczematous or urticarial lesion or just pruritus. And there may be a diagnostic delay that affects their actual response later. So in those cases, we need to do immunofluorescence and rule out other diseases, and sometimes we go on with the treatment. There are a lot of comorbidities with bullous pemphigoid, including neurological disease, like in 30 to 50% of patients. They may have dementia, Parkinson's disease, stroke, or multiple sclerosis. At the beginning, when the article came about 10 years ago, I thought, okay, these patients are older patients, over 70, and majority even over 80. So of course they have more dementia or these conditions. But there were also studies that there is basically the antigen involved in bullous pemphigoid, the same antigen is in the brain. So maybe the antibodies are against both. So I don't know, like there are more studies, but we see definitely more dementia in these cases, and they have more psychiatric disease and other comorbidities because of the age. So treatment is a challenge. It's a chronic course, on average, even 9 months to a year, and some patients have relapsing disease, so even may take years to get better. At the beginning, we can start with clobetasol, you know, the most potent steroid, 20 to 30, even 30 to 40 gram in extensive disease. The standard of treatment is systemic corticosteroids, 0.5 milligram per kg for mild to moderate. And if they don't respond, even 0.75 milligram per kg, which is a high dose. So as you know, like we have to do all monitoring, you know, make sure patient doesn't have cataract, glaucoma, you know, check for other comorbidities. It may affect the sleep. It may affect definitely sugar, you know, they may get chemical diabetes. We have to check for osteoporosis. Generally, I automatically put them on alendronate or bisphosphonate. But again, in elderly, we have other issues. Sometimes their kidneys involved. So going on the next, so we use adjuvant therapy to taper prednisone over 4 to 6 months. But these are not also easy drugs. You know, we have to do a lot of monitoring for patients that for reasons we cannot give immunosuppressant, we may give doxycycline or dapsone. And now we have targeted therapy for pemphigoid like rituximab, but it's not the same effect as pemphigus, you know, or rheumatoid arthritis or lymphoma. We use the rheumatoid arthritis or lymphoma protocol. It's not easy to get that. They have to fail other, you know, immunosuppressant, and then we can move on to rituximab, which is an IV drug. Intravenous immunoglobulin, there are some evidence and the new guideline for EADV, European Academy of Dermatology, is talking about IV immunoglobulin, intravenous immunoglobulin, but it's not a routine. And again, in elderly can affect the kidney, and, you know, the volume that they're getting is not tolerable. Omalizumab, we use it off-label, which is an anti-IgE. We use Xolair or omalizumab also in urticarial patient. It's a pretty safe drug. So sometimes in the urticarial phase, we can get it approved and we don't have a lot of choices, but sometimes even we combine with steroid and other, and again, dupilumab or anti-IL-4 13, as we talked, it's mainly for atopic dermatitis, but in the pre-bullous phase, sometimes we can get it approved, especially we already use prednisone and immunosuppressants. So this is on ODB, but it needs a special access program, EAP, and we need to do a lot of paperwork. But in some of our patients can actually be effective. So there are a lot of targeted therapy for pemphigoid, but when we have a huge list, we know none of them are that effective. But as I said, rituximab on top of this, and some of our like psoriasis medication, they are used, but not very impressive. So something that I really want to bring to your attention is drug-induced BP. And this came in the last few years. So dipeptidyl peptidase 4 inhibitor, DPP4 inhibitor, or gliptins, we know that basically they may induce bullous pemphigoid. So not as much Januvia than Galvus or the other one, I forgot the name, but Trajenta. But still with Januvia, we are concerned. So it may take a year or even more to show bullous pemphigoid. So it's not quick that they started yesterday and they get bullous pemphigoid tomorrow, you know. So it may take over a year. But the question is, when they have bullous pemphigoid, we start the treatment anyway, because this is a challenging disease. And if we stop the gliptin, does it really make, or it may just trigger bullous pemphigoid, then it goes on. So the studies so far wasn't that, not a strong evidence that stopping gliptin make bullous pemphigoid go away. However, we still recommend it to switch to another anti-diabetic drug. Immune checkpoint inhibitor, PD-1 inhibitor, and PD-L1, like nivolumab and like the names are difficult. They may also cause bullous pemphigoid. Dopaminergic and anticholinergic drugs, like they may cause, and diuretics, especially spironolactone, also may induce bullous pemphigoid. And I always finish my talk with the most challenging cases I see at the hospital, especially with ethnic backgrounds we have in our patient population. You know, we have a lot of HLAs, and this is Steven Johnson or TN. And even during COVID, I saw patients that like after they had COVID and they got Steven Johnson, whether due to the drugs or, you know, overall the impact of the disease. So if we don't treat these patients early, it may cause really, really more higher morbidity and mortality case. And the highest morbidity is blindness. So it's not something negligible. So like if you're a prescriber, which you are, like we have a mnemonic Satan, like Septra, sulfasalazine, allopurinol, tetracyclines like minocycline, anticonvulsants, carbamazepine, dilantin, lamotrigine, phenobarbital, nevirapine, NSAIDs, and now we have immune checkpoint inhibitors and a lot of targeted therapies too. So if you see any sign of like any severe rash, mucous membrane involvement, severe conjunctivitis, facial edema, bring to our attention, you know, call me, call ICU people, send patient to emergency, because the sooner we treat that we have like the better impact. And our routine is admit this patient, start like to do conservative therapy, as well as we start with a combo of IV methylprednisone, cyclosporine, and Enbrel. And so far, like this is like kind of the routine in Canada. Some countries, they like even in US, they start with IVIG. But overall, these patients need attention. Their eyes need to be checked. You know, their other mucous membrane, including genitalia, urinary area, needs to be taken care of. Otherwise, they may get a lot of, you know, comorbidities after. And the HLA is related to this drug reaction. And in some countries or some patients, some of our colleagues routinely check for these HLAs. You know, allopurinol, for example, in Han Chinese, HLA B5801, carbamazepine, I really recommend to our neurologists to check it. I know there is a cost for it, but especially in Asian population, I think it's a better, like, I mean, even Southeast Asian needs to be checked, HLA B1502. And in HIV patient, before we start, you know, nevirapine, it's a good idea to start to do HLA B5001. And that's the end of my talk. So if there's any question, I'll be more than happy. And thanks for listening. No question? So I know many of these biologics are even more used by our colleagues like Elaine Young or our gastroenterologist, and generally the challenge that comes, or the question comes, you know, when patients have IBD or severe rheumatoid arthritis, you know, it's inevitable that they need to go to these drugs. Then when it comes to like psoriasis or eczema, some people feel like it's too much. But the fact that we see these patients, how much their life is affected. And this is something I hear almost every day, like patients that they are cleared with biologics, they really appreciate that they get back to the normal life, the life we have, like things that we don't appreciate on everyday basis, going with a short sleeve outside, or, wearing short or skirts and going, to a party, or having a better sleep, like because we are not itchy, So this is the challenge. And I just wanted to bring to your attention that we have now more drugs to offer also for our internists to know these drugs, at least be comfortable with the name of them and some of the side effects. So hopefully this talk was helpful to our group, and I'm more than happy to answer any questions. And nothing in the chat. So thank you very much. So bye. Have a good day. Enjoy your rest of the day. Bye.